First of all, a very warm good afternoon. Welcome to the weekly EPG teaching program of Academy of Pediatrics, Uttar Pradesh, which is being run for the last 1.5 years, every Friday, 3 to 4 p.m. And we are very thankful to all the postgraduates who are patronizing it, to the learned faculty members who are sparing their valuable time and sharing the knowledge and expertise for the benefit of the postgraduates of Uttar Pradesh, and also those who are joining from outside UP. And I welcome all those faculty members like Dr. Kamran Afzal is here. A lot more will be joining from the various medical colleges of UP. Very warm welcome to you. And before we proceed, it's my proud privilege to introduce our experts for today's PG teaching program. And before I introduce my experts, I'd like to thank Dr. Anita Mehta, the BRD Medical College Pediatrics Department HOD, for taking up this case for her department on her behalf, and Dr. Ajeet Kumar Yadav will be mentoring the case for the postgraduate third year, Dr. Neha Roy. So I'd like to introduce the various faculty members, the mentors, and the experts. So Dr. Anita Mehta is right now busy in the exam in Bareilly SRMS. She is informed, and very graciously she took up this case whenever I requested her. Dr. Anita Mehta is a MBBS from LRM Medical College Meerut and MD Pediatrics from BRD Medical College Gorakhpur. She is presently the professor and head Department of Pediatrics of BRD Medical College. Awards, a lot of awards and publications, post-MD, 14 years of teaching experience, 10 of IYCF, NRC, and various modules, more than 15 publications in various national and international journals and book chapter, and she is especially impressed in IYCF and pediatric nutrition and pediatric neurology. Dr. Ajeet Kumar Yadav, he will be mentoring the case. He's the assistant professor, Department of Pediatrics, BRD Medical College, Gorakhpur, and he has just joined 4 months back to the UPSC. As you can see, he's now the most the budding the faculty members, and will be the future for the AOP UP. MBBS from KGMU and MD from LLRM Meerut. He's been a bright student, a gold medalist, an MD exam, post PG experience in KGMU Lucknow, PGI, and Dr. RML Hospital, New Delhi. And is in charge of the PG teaching program of the BRD Medical College, Gorakhpur. Welcome, Dr. Srikanta Basu, sir. Director Professor, Department of Pediatrics, Lady Hardinge Medical College, and Kalavati Saran Children's Hospital, New Delhi, the most busiest happening place for the children all over the North India. And he's the chairperson of the cardiology chapter of IAP, in charge of the cardiac clinic, Kalavati Saran Children's Hospital, 70 publications in PubMed Index journals, 25 chapters in textbook of pediatrics. And he's FIAP Ashok Nathwani visiting fellow, RCPCS London, and WHO visiting fellow, University of Liverpool, UK. Sir, we are very thankful that you spared your time out of so many busy engagements of yours today. And with such a eminent cardiologist of you, I think with your knowledge, the PGs are going to be definitely benefited a lot.
Thank you so much.
Munesh,
thank you so.
Tomar, very own from Meerut, NB Fellowship Pediatric Cardiology, FACC Consultant Pediatric Cardiologist from LRM Medical College Meerut, and the Director of Pediatric Cardiology, Nutima Hospital Meerut. And she has a lot of achievements to accredit. Thakur Ulfat Singh Award for the Best MD Student, Best Teacher Award 2020 UPIMA, Vice President National IAP Pediatric Cardiology and Fetal Forum, and the National Coordinator of the NB Pediatric Cardiology Webinars. She has 115 publications to accredit, and has book to accredit on echocardiography in congenital heart disease and a practical approach. And these are into areas of interest, obviously. Teaching pediatric cardiology, for which she is very passionate, and social service, through which this branch offers a lot of scope for that. So this is in brief about the faculty members. And Dr. Neha Roy, the third year PG, is going to present a case, as you all know, about the cyanotic congenital heart disease. I request all the postgraduates, though Dr. Neha will be presenting, but you feel free to interact to various queries raised by our experts, and so that all this becomes a very interactive and stimulating session for everyone. That's how we in the PG learn. And this is like a exam like scenario which we are trying to put up so that the PGs of UP are benefited and well prepared for their exam. With these words, I hand over to Dr. Ajeet Kumar Yadav to take over the proceedings. Thank you.
Thank you very much, sir, for your kind introduction. And on behalf of BRD Medical College, I take this opportunity to present this case by our third year PG, Dr. Mehta. Dr. Mehta, over to you. Start your presentation, please.
Shall I start, sir?
Yeah, sure.
Okay. Good afternoon, everyone. I'm Dr. Neha, President of BRD Medical College. So today I'm going to present case history of patient named XYZ, 5-year-old female, resident of Maharajganj. She was admitted to our department on 7th of May 2022. The informant of history was mother, so it seems to be reliable. The chief complaint as on 7th of May 2022 was on and off fluid escalation of lips, fingers and toes for the past 4 years and on and off squatting posture attained by the child for the past 3 years. One episode of sudden loss of consciousness was there 1 day back for 30 minutes. History of present illness. According to mother, she first noticed bluish discoloration of lips and fingers when the child was 1 year old and was playing. It was associated with hurried breathing and got relieved by holding the child in caressing position. By flexing the limbs for the past 4 years, she used to have such episodes on and off while crying and playing. With time, number of episodes had increased. Earlier, she used to have 2 to 3 episodes per month, but now for past 1 year, she is having 4 to 5 episodes per month. For past 3 years, mother noticed that child used to develop bluish discoloration of lips and fingers with difficulty in breathing while running around and playing. When child used to adapt squatting position for few minutes, which relieved the symptoms, and recently child started avoiding activities which required exertion. 1 day prior to admission, she had 1 episode of sudden loss of consciousness while playing, which lasted for approximately 30 minutes, as stated by the mother. And according to her, she was unresponsive to any kind of verbal stimuli during that period. There is no history of tightening or jerky movement with uprolling of eyeball, or no history from frothing from mouth, no history of stool or urinary incontinence. And it was relieved after reaching government hospital on providing oxygen and some IV medications. And patient became oriented and there was no focal deficit after that. Negative history. There is no history of recurrent respiratory infections. There is no history of limb swelling. There is no history of fever, no history of chest pain or hemoptysis. There is no history of any kind of joint pain or myalgia. And there is no history of vomiting, headache or altered sensorium, and no focal neurological deficit after that. Past history. There is no history of...
I would like to interrupt. Now, come back to the history, right? Now that normally we as examiner, after the presenting history is complete, we'd always like to ask, because I am sure this is on the exam mode as well, isn't it? Apart from the, about the case, a little bit about the exam mode as well. Normally after presenting the case, we generally ask what are your possibilities and how do you go about it? Can you come to the first slide? First slide, yes. Yes. So off and on bluish discoloration, fingers and toes 4 years, off and on squatting 3 years, and 1 episode of sudden onset of consciousness, right? So,
yes,
what is the interpretation? Most likely it is case of
cardiovascular system.
Cardiovascular.
Yes.
And definitely there is no, most likely we're dealing with a child of cyanosis, right? Can they sometimes in the exam also you may not get the, you may not get the direct history. Sometimes you get a history of bluish discoloration, but at that time we're not able to pinpoint which system is involved. So what could be the other system from this history which is involved, and history is important for that as well.
Yes, sir. Sir, for cyanosis, we should keep in mind other causes like those involving respiratory system and those involving CNS system, and also breath holding spell done by the child.
Right. So next page you come to that. So these are important. Next slide. Next slide.
Yes, sir.
from this history of presenting illness, can you differentiate whether, because that is the most common, though 5 years is slightly more for breath holding spell, it is usually in the younger age group, but since going by the history, it can still be traced to that. The most common, you can say, differential will be your, what you said, breath holding spell, isn't it? So
Yes,
from the history, how do you differentiate between breath holding spells and a so-called hypercyanotic spell?
Sir, in
Which
case
are
of
the
breath,
points?
Sir, in case of breath holding spell, there is a phase of apnea followed by cyanosis. While in case of sir, cyanotic due to cardiovascular system, when there is cyanosis, then it is followed by hyperapnea. So breath holding spell is mainly provoked by any kinds of anger or frustration. But any stress like feeding or crying can also stimulate cyanosis in case of severe. And in case of say breath holding spell, previously the child is usually normal. And in case of cyanosis due to cardiovascular system, initially the child will have cyanosis and it will increase with exertion or any kind of stress.
Right. So you are covered most of the point. Yes, breath holding spells normally is brought on by so-called, I mean, sometimes the child is very kind of, you say, stubborn, obstinate. If he's denied something, he's on some small pretext, he starts crying. After crying, he holds his breath. Whereas a child, and then he goes apneic. Whereas a child with hypercyanotic spell, usually on any form of exertion, his cyanosis or bluish discoloration increases, isn't it? That is the main difference. And apart from that, there are certain precipitating factors we need to ask. One, you have already told, it is like you told fever is one factor. Sometimes it is brought on by while defecation, while child is a passing stool or straining something, that can be brought there. The other factors again, sometimes again, it could be any episode leading to any form of dehydration or some fluid loss, but sometimes the spells are brought. So this should come in the history. I must say you have taken a good history. Most of the time, PGs, what happens is takes a positive history of 4 or 5 lines, that they straight away they go to the negative history, right? So this is important. We have to look at also the precipitating factor which has brought in, whether it is cyanosis or not. And again, since we have told squatting generally when the child starts walking and after that starts slightly running and all, then the squatting start after 1.5, 2 years, after 2 years it happens. Apart from that, sometimes these children will also present with the history of complication. So that should come in the history as well. Apart from precipitating factor, are there any associated lesions or associated symptoms that can be pinpointed towards it, right? So these are some of the important points I have to last. And has there been any previous hospital admissions prior to that? Any previous hospital admission? Are these hypercyanotic spells or either just an increase in cyanosis going by the history?
Sir, there is no history of prior hospitalization, means before this admission.
So she never had this typical hypercyanotic spell, is it?
No, sir, not this typical. Means the day on which she came to us on 7th of May, before that there was one episode which lasted for 30 minutes and that made the mother worry. But before that, she used to squat and flex the limbs and she used to take some multivitamins, but there was no such severe episode which made the mother think to come to hospital.
Right. So probably this is the first pill only when, I mean, that is, I'm sure history you have taken very succinctly. Then Dr. Munesh, you would like to add something?
Yeah, and, What about first year of life, Neha?
Ma'am, actually the child is third female child, and when the child was 2 months old, then her father died due to some road traffic accident. So in language of mother, she was in kind of agony at during the first year of life, and she did not notice any kind of bruise escalation in her language. And so at age of first year only, she noticed such bruise escalation of lips and fingers.
Okay, and like so-called cyanotic spell. No, she did not give any history of excessive irritability and getting blue. Means like for that.
She had, during playing and during crying, she used to have such episode.
That was after means when started squatting and all. Means 1 year beyond second year. But in first year there was no specific history.
No, ma'am, there was no such.
And she did not notice basically.
Yes, ma'am. She did not notice any kind of history.
Okay, and she was never evaluated for these issues?
No, ma'am. No, ma'am. She was never evaluated. This is her first
Oh.
admission.
For the first time, she is getting medical attention for
Yes.
her illness.
Yes, ma'am.
And all this while she has been growing well, milestones have been achieved normally.
Yes, sir. All the milestones were within normal limits. She was developmentally normal, and she
Okay,
used to
fine.
play
Even
with
the
that.
growth is normal, no faltering of growth. I
Yes,
mean,
sir.
weight and everything and height
No,
and
sir.
everything.
Sir, by anthropometry, she is
No, not
stunted.
anthro. By history. What?
Sir, yes, sir. According to history, sir, mother had noticed that her growth was delayed as compared to other siblings.
Yeah,
But
that should come in the history. This is very important point. Why this is important point?
yes, sir, because it's chronic illness, it will lead to stunting and
Not yes,
underweight.
chronic and even anoxic spells and all, they will have a bearing on the weight as well. Now tell me from history, how can you differentiate between a cyanosis of pulmonary origin or cyanosis of say cardiac origin? From the history, which points are important?
Sir, in case of cyanosis will be there due to pulmonary origin, then she will need oxygen support or any kind of hospitalization. But here, due to posture, with the help of posturing only, when the blood flow improved, then there was decrease of cyanosis. And
No, but that is, I mean, maybe the parents never thought it is important, they never took it. Normally, even cyanotic baby also, when the child is in blue, if you normally give oxygen if there is spell and all, isn't it? That
yes,
is an afterthought. Any other point, any other in the history which you'd like to elaborate on? What happens to the child with pulmonary, cyanosis pulmonary origin?
so during normal activities also the respiratory rate will be increased and there will be retractions appreciable. But in case of such cyanotic spell, only at that time there will be hyperapnea.
Maybe one point is they say sometimes there is agitation. With agitation, maybe cyanosis may be less in respiratory, though in severe cases the cyanosis might increase. Whereas in cardiac cases, invariably, whenever the child is agitated, irritable, crying, his or her cyanosis generally increase. And sometimes we say there is kind of happy kind of cyanosis with tachypnea, those of cardiac case. In generally with respiratory with cyanosis, child will be more, you can be more at distress. But again, there are conditions in which, again, and then there is a recurrent episode cyanosis. Sometimes what happens in pulmonary origin cyanosis abates, become all right. Again, the child has one episode, again becomes cyanotic. Whereas in cardiac origin cyanosis, it remains there if one is careful to observe it. So these are some important points. Other than that, again, since we have already told about the history of say focal deficit, or I'm sure we are looking at the complication we can discuss later. But in history, did you ask anything related to any related to heart failure, symptoms of heart failure in this child?
Yes, sir.
Or
There
do you think this need to because this child has cyanosis, no need to ask about failure? I mean, can you clarify on that?
Yes, sir. Sir, we should look for those diseases means having cyanosis and increased pulmonary blood flow. For that, I asked that whether there was any kind of pedal edema and whether there was any kind of dyspnea. So, sir, dyspnea was not of that great that it limited the child activity.
Apart from dyspnea, what are the other features of failure in a child of cardiac origin?
So there will be
pedal edema. How often do you see? See, very rarely. Only in an older child, we normally see pedal edema, rheumatic and all. Generally, pedal edema is not there unless the child is malnourished also. Generally, it might be present in the dependent part in a smaller child. Apart from pedal edema, what are the other symptoms of heart failure in a child we need to ask?
So there will be fatigue and
in a younger child, what are the points in Munesh was asking? Before 1 year, what could feeding difficulty? See? Yes, right. Then you have to ask in the history whether the child ever had a history of feeding difficulty or not, right? Though the classical, which you call, what is called suck
cycle, yes.
Suck cycle is there or not, right? Or the child excessively sweats while feeding and becomes all right when they're taken up in the upright position. And the child grows older, then easy fatigability, unable to climb stairs. And though it could be part of cyanosis as well, but as a failure, this is again part of symptom as well. Right. So the symptoms of failure need to be asked. In an older child, sometimes the presentation of say vomiting or even GI pain and all, sometimes there might be other additive factor. So these are some of the important points you need to ask. You have asked about the complication like other complication. Dr. Munesh, anything?
Neha, all detailed history Dr. Basu has discussed. The important point is basically your presentation is loss of consciousness. So what is your thought about that loss of consciousness? And after that, just summarize your history and we'll discuss in detail line of your thinking.
In this case, loss of consciousness can be due to several reasons. Like first, there can be decreased cerebral blood flow due to polycythemia, and or due to anoxic spell, there can be decreased cerebral blood flow. Or the third thing we can think of cerebral abscess, but there is no history of fever here. There is no history of increased ICT or vomiting, or there is no history of focal deficit. So we can rule out cerebral abscess, and there was no history of focal deficit. So we can rule out any kind of hypoxia that leaded into it. One differential can be arrhythmia. Due to arrhythmia, there can be syncopal attack which lasted for 30 minutes.
Okay, that is too long, but obviously that is so. First possibility is cyanotic spell. Severe spell. And we need to we need to prioritize our differential diagnosis. So first is the severe cyanotic spell. Severe can happen in any child with cyanotic heart disease, any cyanotic patient, and severe you always don't get focal deficit. That is another limitation, because sometimes we have small multiple infarcts. And in examination, these kids hard. I am imagining a sick cyanotic baby. They hardly walk. They're most of the time in the bed sitting with an eater's position. So that is their usual. But they sleep in that position. So it's difficult to pick up that. But when it is multiple infarcts, clinically you won't get the. But obviously, and recurrent hypoxia. He is having squatting for 4 years, and before that, definitely he must be having spells, he or she. So that there was not any hypoxic damage, this is difficult, could be associated. Another thing is, because there is anemia which is prevalent everywhere, especially to that society. So microvascular RBCs which are iron deficient, they have very high tendency to get sludging in microvascular circulation, and they cause CVA. If you do CT scan, MRI of these babies, you get very bad picture into that. So obviously, first thing is your cyanotic spell. Second is CVA, then abscess. Obviously, no history of fever, no vomiting, no this. But still, sometime we'll get that also. So it likely not, but this is my differential diagnosis for cause of cerebral vascular accident. This is CVA. CVA means it's CNS presentation, but severe hypoxia, most likely because of cyanotic spell. But other factors, obviously, we can't rule out. It's such a prolonged unconsciousness, we have to plan the neuroimaging. So in short, just summarize your history, because we have limited time.
Now, a 5-year-old female born to non-consanguineous marriage having normal birth history was apparently asymptomatic till 1 year of age, after which mother noticed bluish discoloration of lips and fingers while crying and playing, and these episodes increased with time and got relieved on attainment of squatting posture. One day back, she had one episode of loss of consciousness for 30 minutes with no residual or altered sensorium and no focal neurological deficit.
Okay, so this is cardiac or non-cardiac, like we have to go according to pediatric protocol. So cardiac or non-cardiac?
Ma'am, the attainment of squatting posture and the history of cyanosis favors in cardiac.
Congenital or acquired?
Ma'am, it's congenital, because at 1 year.
There is cyanosis started so early, so it is congenital. Okay. Yes, so cyanotic or acyanotic? Cyanotic.
Cyanotic. Yes, ma'am.
Cyanotic. Now you have three, in fact,
limbs,
columns. So where you are thinking by history, where you are, what differential diagnosis group wise in cyanotic heart disease?
Ma'am, there is no history of recurrent chest infection, and there is
no. You just tell me cyanotic heart disease. You have three differential groups.
Yes,
Dr.
ma'am.
Basu has passed
Into,
everything in history. One is,
ma'am,
first is,
ma'am, this falls into those having decreased pulmonary blood flow. So,
yeah,
fellows,
what do we call that?
ma'am,
Top
fellows,
physiology.
fellow physiology.
Okay,
Yes,
fellow
ma'am.
physiology.
Yes,
Not top physiology, because the number of diseases are included into that. Second,
Epstein anomaly can be
no,
there.
beta. Top physiology. Second is admixture lesion. Dr. Basu asked about the CHF. History of CHF is there or not. He wanted to just to think you on that line. Admixture lesion means TGA, TAPVC, single ventricle without PS. So miss where there is increased pulmonary blood flow. So that is admixture physiology. Third is Eisenmenger group. Okay.
Yes, yes,
In a small baby started at 1 year of age, all this, it doesn't fit into, but at this group you should know. Fourth is miscellaneous, like your Epstein anomaly, systemic venous anomaly. These are the rare things.
Right.
That is fourth. Okay. So you have to have, when you are seeing a child with cyanosis, these four things should be in your mind. I'm dealing with the top physiology, I'm dealing with admixture lesion, I'm dealing with Eisenmenger syndrome, or I'm dealing with something like rare Epstein anomaly or a system event. So on that, you ask, like you will go back and ask your history. On that, you will go back and examine your patient to when you are going to present a case in your exam. So that algorithm should always be in your mind. Congenital heart disease, cyanotic, acyanotic. Acyanotic, it is pre-tricuspid, post-tricuspid, or ductal, and cyanotic, you have these four things. Okay, so that physiology should always work when you are dealing with a cardiac patient. Anything else, Dr. Basu, you want to add?
Same thing. Yeah, you're absolutely right. Basically, broadly, we have to divide into three categories. All the PGs, as Dr. Madam has told, those with decreased pulmonary blood flow, which we call them top physiology. Remember top physiology. In exam, no examiner will ask what is the diagnosis. They will always ask what is the differential diagnosis. So if you give differential diagnosis, more or less your job is done. The other group is admixture, which leads to cyanosis along with the failure. And the third group is severe PAH. From history, you can actually rule out the third group. Apart from age, if you ask, no history of left to right, what is the classical history of Eisenmenger's? What is the classical history like? Neha.
So previously there will be episodes of recurrent pneumonia and recurrent hospitalization.
Right. After that?
After that, sir, there will be distress, and then the patient will give history of cyanosis.
No. Before cyanosis, the mother will say कि suddenly बच्चा डॉक्टर साहब पहले जैसा बीमार नहीं रहा, पहले से ठीक हो गया, अभी इसको हॉस्पिटल जाने की जरूरत नहीं पड़ती है. Mother feels the baby is getting better, but by that time mother feels baby is getting probably, I mean, baby or child would usually present slightly late. Then probably she has lost the battle,
That
right?
window.
Yeah, that window, right? So by history, you can jolly well rule out severe PAH. So ultimately, it boils down to decreased top physiology versus admixture lesion, and rarely with Epstein and all those things, right? So this is very, very important. And if you keep that in mind, more or less, I mean, cyanotics आप लोग डरोगे नहीं cyanotic heart disease. अगर आप broadly इस group में divide कर लेते हो तब ठीक है, right?
I think we should move to
examination. Yeah, we should move. Yeah.
So by history, where we are, Neha, by history, we are into which group? Top physiology, admixture, or Eisenmenger, or miscellaneous?
Top physiology.
Top physiology. Excellent.
Yes.
Good.
On doing general examination, patient was sick looking, of thin build, lying comfortably on couch, was conscious and oriented to time, place, and person. Her vitals were: pulse rate was 112 per minute, normovolumic was regular, having no radial or radiofemoral delay, and pulses were palpable in all the four limbs. Respiratory rate was 32 per minute and was of abdominothoracic type. SpO2 was taken in all the four limbs and was found to be different. It was 79% in upper right limb and were lower in other and was different in other limbs. Temperature was 98.6 degrees.
Neha. So what is the meaning of this 79, 81, 59, 75?
Ma'am, in case of...
Is it possible? This is upper limb, no? 79, 81, yes, and 59, yes, 75 lower limb.
Yes, ma'am.
Is it possible?
Yes, ma'am. In case there will be mixing of blood which is delivered to the body, then the lower limb will have less saturation as compared to right upper limb.
No, when we have what is called
Pulse oximetry test.
You are taking yourself into
trouble now.
different zone, but it is okay. So when do you have lower limb desaturation in comparison to upper limb? What is the cause?
Ma'am,
There is
in
only
case
one
of
diagnosis.
obstruction, aortic stenosis or coarctation of aorta, the lower limb will.
No. This is PD Eisenmenger. PD right to left, Eisenmenger syndrome. Because of coag, because whatever, means PD is right to left. So your unpurified blood is going to lower extremity. So lower limb saturation is low and upper limb is normal, not low. Here upper limb is low, not normal. But do you have any explanation for difference of almost 16% in right and left limb?
Mixing of blood is taking place post.
Same blood will go to both limbs, na? Both lower limbs same. Upper lower chalo chhod do, hai na? But both lower limb would be at like Neha. This is very important when you are going for exam or anything. Think what I am writing. Examiner nahi check karega pulse saturation. ठीक है? So is it possible? Physiologically जो चीज possible नहीं है because sometimes ना there is time difference. अभी मैंने ये saturation लिया, अभी ये लिया, इतने में बच्चा थोड़ा move कर गया. So saturation ऊपर से alter हो गया. Okay, heart rate alter होते ही आपका saturation change हो जाएगा. So आपका भले ही 1 minute difference है, but hemodynamic has changed because of his activity. You may get a lower saturation. You need to understand you can't have two different saturation in left and right limb. You can have different saturation upper and lower limb. The explanation for that, but with top physiology, the mixing is inside the heart. Okay, means all limbs have almost same saturation. 2 to 4% difference chalta hai, but not 15%. Okay, so always think twice before writing the numbers. You can't have, आप अगर यहाँ 70 or 75 लिखते तो चलता, but there is no need of writing both lower limb saturation differently. समझ गए? नहीं चाहिए. Don't give all so many numbers. Don't give to the examiner unnecessarily. Like ना हम रुक गए. So you just need upper limb, both upper limb saturation. That is for the newborn. Otherwise, बड़े बच्चे में you need one upper limb, one lower limb saturation. And it's when we are talking about in top physiology type thing, or even TAPVC, or even TGA, your mixing is inside the heart. Okay, and it's got me.
Yes, ma'am.
So this 5975 doesn't exist. Okay.
Okay.
Chalo.
Okay. Ma'am, the BP was 98 by 56 mmHg in upper limb and was 90 by 48 mmHg in lower limb in taken in supine position. On general examination, pallor was absent, icterus was absent, and cyanosis was present of central type.
नेहा अब pallor तुमने absent बोला, इसमें बड़ा एक important point miss हो रहा है, जो कि कोई भी सुनना चाहेगा. तुमने you told all the student when you have told the child I am dealing with a child of cyanotic heart disease, what do you expect in this child as far as his hemoglobin is concerned vis-a-vis clinical pallor or was concerned?
Sir, there will be hyperemia. There will be congestion of the.
And plethora है कि नहीं ये बताओ ना. Pallor,
yes,
I mean, this is important because isn't it? फिर वो somehow gel नहीं करता. Pallor absent बोलने पता नहीं चला. Pallor नहीं है. ठीक है. That can be whether the child is hyperemic or plethoric है कि नहीं वो बताना पड़ेगा. ठीक है. It's important. Yes, बाद में we'll discuss in the management क्या करना क्या नहीं करना. Yes, please move ahead.
Sir, there was, sir, I mentioned here, in eyes, there was bilateral conjunctival congestion present, peripheral to the limbus part. And lips, there was cyanosis present. Oral cavity showed cyanosis of lips and the tongue was of geographic type. Chest was bilaterally symmetrical. There was no deformity of visible vein. Abdomen umbilicus was inverted and was centrally placed, and all quadrant was moving equally with respiration. There is no dilated vein or scar mark. Genitals were normal, and limb have grade 2 clubbing present both in upper and lower digits, and the angle was obliterated as we can see here. On doing the anthropometry, her weight for age was 11 kg, and it felt.
Any other finding on general physical examination would you like to say?
Sir, there was no visible pulsation or engorged vein present, and
apart from that,
sir,
any
there
other
was no
complication of this cyanotic heart disease
yes, sir.
Would you like
So
to
there
mention?
was no petechial hemorrhage or there was no Janeway lesion
Yes.
or Osler's node present.
No
any, you
peripheral
can say
stigma of this.
infective
Infective
endocarditis.
endocarditis.
Right. I'm just interrupting because 2 days ago I was in an exam where short case, in a DNB exam to be precise, where a short case of CVS was given to examine the CVS. I mean, you won't believe majority of the students, they did not examine the peripheral vascular system or CVS peripheral sign. The straight away they went to pericardium and auscultation and all those things. So all the PGs, I know now that you know a cardiac case, you do in detail, but whenever some exam is kept, somehow we tend to miss out the small thing, details and all. Because again, so there's so many findings in peripheral science. So many a time it may not be there, at least make it a habit to examine diligently the peripheral signs of involvement of cardiovascular system, be it congenital heart disease or be it rheumatic heart disease. Sometimes we may not get age group 7, 8 years. We don't know what it is. So please make it a habit. Always carry with you SpO2 pulse oximeter, which you are supposed to carry. In fact, these children, this boy, this girl was not having any cyanosis visible, but when without oxygen, when SpO2 monitor was put, her saturation was 85%. So the whole diagnosis and everything changed. So if you follow it diligently, all the points, you are very unlikely to miss many of the important points. So this is very, very important. Yes, you can move now.
On doing anthropometry, she was 5.5 years old. Her weight was 11 kg and height was 103 centimeter. Weight for age light below -3 SD. So she was severely underweight, and height for age was between -2 and -3. So she was stunted, and BMI was also less than -3 SD. So she was severely wasted.
One more thing. What is the age of the child? 5+ or below 5?
Sir, 5.5 years, sir.
Okay, fine. If it is below 5 years, you should always go for weight for length or weight for height criteria. Okay. And which chart have you followed?
Sir, IAP charts I have taken.
Okay, this examiner often asks you which chart you are following, right?
On doing systemic examination, first examining the cardiovascular system. On inspection, shape and symmetry of chest was bilaterally symmetrical. There was no chest deformity. There was no precaudal bulge. There was no engorged vein present, and trachea was in midline. Apical impulse was visible medial to mid-clavicle line in 5th intercostal space, and there was no visible pulsation in any other area like aortic, pulmonary, epigastric, suprasternal, carotid, or back. And GVP was found to be 6 centimeter. On palpation, trachea was
or not?
No, ma'am, it is within normal limit. Ma'am, it is central venous pressure. It was 1 centimeter height from angle of Lewis. So JVP was 6 centimeter.
Yeah, so when you say 6 centimeter, it gives an impression that your level is 6. Okay, so you need to specify.
Okay.
So JVP was not raised.
Yes, ma'am. JVP was normal. On doing palpation, trachea was in midline and apical impulse was present in 5th intercostal space, 1.5 centimeter middle to mid-clavicle line. It was ill-sustained and diffuse in nature. There was no thrill and parasternal heave was present, but it was obliterable and of grade 1. On auscultating, in mitral area, there was normal S1, S2. In tricuspid area, there was normal S1, S2, but grade 2 ejection systolic murmur was heard. There was no radiation.
Just go back to previous slide. This parasternal heave. Okay. Okay. Next.
In tricuspid area, there was grade 2 ejection systolic murmur heard. There was no radiation and no change in intensity was appreciated with inspiration and other maneuvers. In pulmonary area, there was normal S1, S2 and grade 3 ejection systolic murmur was present. There was no radiation and it increased with inspiration. In aortic area, normal S1, S2 was heard and grade 2 ejection systolic murmur was present. There was no radiation and there was no change in intensity with inspiration or other maneuvers. There was no other added sound in any other area.
Okay. अब हम रुकते हैं, हाँ? So Neha, go back. So you have 3 murmurs or 1 murmur? Next. Your murmur slide.
Ma'am,
you have 3 murmur or 1 murmur?
Ma'am, in pulmonary area, the murmur was most prominently heard. So there was, I think, my impression was that it was radiation to the tricuspid and aortic area. Only 1 murmur is present in pulmonary area. That is the most prominent one. Ejection
when you
systolic
write like this, I will get an impression that you have 3 murmurs. So when we describe about the auscultation, important point, you have to talk about S1, S2, not per area. Okay, so S1 this, S2 this, any additional sound, there is click or opening snap, and then the systolic murmur, and then the diastolic murmur. Before that, loudness of the sound. Okay, if anything there. So just describe. We can't talk about area wise that S1 is normal here, S1 is abnormal there. Okay, if S1 is normal, it is normal. If S2 is abnormal, it is abnormal. What now?
Yes, ma'am.
So you tell me, first tell me heart sound, S1 and S2, normal?
Yes, ma'am. S1, S2 is normal.
No palpable sound?
No, ma'am.
No palpable sound. Okay. No loud sound?
No, ma'am.
Okay. And you have ejection systolic murmur, most prominent in
Pulmonary
area. Pulmonary area we won't use. You have to describe the space. Okay. Left, second intercostal space. Then this is, one is migration, second is radiation.
Yes, ma'am.
Okay. So that you need to know. You put your stethoscope a particular area, then you just move away from that area and you follow the murmur to say that same murmur is migrating. Okay. In like mitral registration, you get a murmur at apex of MR. You also get in back. This is radiation. Okay. So these two are different things. Then you have one ejection systolic murmur, obviously 1, 2, 5, 4, 2 by you. That is that does not fit. There could be associated aortic stenosis in any patient, may have PSAS both, but that you need to know what you want to convey to the examiner. So patient is having severe heart disease, okay, and his second heart sound is normal.
Yes, ma'am.
Is it possible?
Ma'am, during the initial phase, ma'am, S2 will be normal. Ma'am, later on, ma'am, there will be severe stenosis. Then it will be soft and.
We talk about सीधे बात करते हैं tetralogy, है ना? TOF.
Yes,
चलो region wise बात करते हैं. TOF physiology or TOF. So initial stage, what do you mean by initial stage? It is always TOF.
Yes, ma'am. I meant severity of pulmonary stenosis. Means if it is less severe, then S2 will be normal. Ma'am, P2 can be delayed, but it will be of normal intensity. But in case of severe pulmonary stenosis, there will be soft P2, and further in case there is complete stenosis, P2 will be absent and single A2 will be hard.
No, absent nahi hoti. Like physiology, you need to understand. This is good that. Thank you, Dr. Saurabh, for keeping this case. It is very important for them to understand. Like when we have tetralogy, there is a large VSD. Okay, whatever the physiology of type, there's a large VSD and there is pulmonary stenosis. Aorta is taking majority of the blood from the heart. Okay, so aorta has to be dilated. So aortic sound is usually loud. In this patient, it is there or not, I can't say, but you expect A2 to be loud. And there is PS. Okay, he is so blue, you expect it to be severe PS. It can't be mild or moderate. Then because there is VSD, your whole of the RV blood is going through VSD to the aorta. So pulmonary valve opening ही नहीं होती है. Okay, the flow is small, so loudness of sound come by the opening. So you don't get the sound. So because of that, your second heart sound is single. It is not that P2 is absent. It is so soft you can't hear it, and because it is so loud. So TOF physiology, the second heart sound has to be single. It is, at least for you, it is not possible to get that P2. Very sensitive ear. Yes, I can say Professor Anita, my madam, she could get that, but I can't. So when we talk about TOF physiology, your second heart sound has to be single because P2 is not audible. It is so soft. There is no flow across the pulmonary valve. He's so blue. In 5% of TOF, the pulmonary valve is the main site of stenosis. In TOF, you have infundibular PS. So valve के तो बिल्कुल ही कुछ काम ही नहीं हो रहा ना वहाँ पे. So in 5% of tetralogy, you have the dome pulmonary. Basically, pulmonary valve is dominating stenosis. There you get the pulmonary sound. That is only 5%, and that is also not normal. It has to be low because the blood flow is so small. Okay, So S2 cannot be normal. Severe disease means S2 cannot be normal. एक बात बिल्कुल ध्यान में रखो. Whatever the disease, if child is having severe cardiac disease, like this is severe cardiac disease, S2 cannot. S2 is the most specific thing, but because we can't make it out properly, that's why if S2 is abnormal, this is abnormal. If heart disease is severe, it has to be abnormal. Whether it is VSD, whether it is ASD, whether it is PGA, whether it is TOF, whether it is TGA, TF, anything. Heart disease which you are examining, you are picking up, means it is significant. S2 has to be abnormal. So read S2. This is very important. Okay. For the exam. And murmur, like there's no need of defining murmur at every area. So I'm getting ejection systolic in particular area. I'm getting diastolic murmur in particular area. So you define your murmurs. कौन murmur कहाँ सुन रहा है? Okay, कौन कहाँ radiate हो रहा है? But अलग-अलग space में same murmur की हम बात करेंगे तो लगता है we are talking about 3 or 4 murmurs. जबकि हम एक ही murmur की बात कर रहे हैं तो that will create confusion. Plus आपका time ले लेता है वो, है ना? तुम 4 बात कर रहे हो same बात 4 बार में, तो आपका time examiner को लगाओ ये तो बार-बार वही बात बोल रही है. नहीं, हमें point बिल्कुल to the point बात करनी है. S1 मेरा ये है, S2 मेरा single है. There is no additional sound, there is no click. There is ejection systolic murmur of particular grade in this area. It is not radiating or radiating, and there is no diastolic murmur. There is no S3. There is no S4. हो गया, है ना? उसके पहले कार्डियोमेगली नहीं है वो आप बता ही दिए, जेवी केस नहीं है वो आप बता ही दिए हैं, ठीक? So no venous prominence है, ये सब आप already cover कर चुके हो. So sound and murmur you have to be very specific, and ये बात रट लो. Severe disease second heart sound normal नहीं होता है. Okay.
Okay.
एक दो just 1 or 2 points I'd like to add. अभी जैसे मैडम ने बड़े अच्छे से बताया, क्योंकि you have to summarize किस एरिया में prominent है. For a suggestion, sometimes we combine inspection and palpation, then give our finding. You might be asked about parasternal heave and all those things. You can give your interpretation किस तरह का है. एक चीज बताओ, टॉफ के बच्चों में क्या मिलेगा तुमको? Do you expect lot of parasternal heave? किस तरह का मिलेगा तुमको?
Ma'am, sir, parasternal heave will be expected because there is concentric hypertrophy of right ventricle.
Heave कब होती है? अब चलो.
अब तो हाँ, उसलिए मैंने पूछा था.
When we expect heave?
Ma'am, in case of right ventricle hypertrophy, we expect parasternal heave.
देखो नहीं, heave मतलब pressure. Okay.
Yes,
and left parasternal area में heave की हम बात करते हैं when we talk about right ventricle. So when there is a large VSD, आपका RV को तो कुछ करना ही नहीं पड़ रहा ना. Understand? So whatever the RV is facing systemic pressure, but वो VSD के through eject हो रहा है ना, उसको इसने अपना भार VSD पे छोड़ दिया and it's going through aorta. So you don't expect heave in tetralogy, usual tetralogy. A very small number of TOF have a smaller VSD and you get heave and this and that blah blah. But for you,
yes,
VSD TOF में heave नहीं होता है. Heave means you are talking about suprasystemic RV pressure, means PS with intact septum or small VSD. Got it?
yes, ma'am.
जब भी पल्मोनरी प्रेशर जब बढ़े, जिसके ग्रेडियंट के अगेंस्ट जब पुश करती तब आपको मिलेगी. ठीक है, तो ये आपने डिस्क्राइब किया. सेकेंड पॉइंट जो कि जब एक आदत डालो अभी से, हार्ट साउंड सर S1 इज ऑडिबल, इंक्रीज और डिक्रीज जो भी है, S2 इज ऑडिबल, डिक्रीज और इंक्रीज, स्प्लिट है कि नहीं है, उससे तुम्हारा A2 P2 दोनों कवर हो जाएगा. समटाइम्स एग्जामिनर विल माइट आस्क कि भाई रिवर्स स्प्लिट कब बोलते हैं, तुम्हारा पैराडॉक्सिकल स्प्लिट कब बोलते हैं, वाइड एंड सिक्स, ये बड़ा फेवरेट क्वेश्चन होता है. खासकर डॉक्टर मुनीश के तो कार्डियोलॉजी वाले ही तो उनके लिए दाएं हाथ का खेल है, बट पीडियाट्रिशियंस के लिए बड़ा मुश्किल होता है टाइम. फॉर एग्जाम्पल इफ आई आस्क यू कि क्लिनिकली तुम कैसे बोलोगे इस बच्चे को, तुम्हारा रिवर्स स्प्लिट कैसे बोलोगे, हाउ डू यू से? एग्जाम्पल के तौर पर एग्जाम्पल दे रहा हूँ, पीपल माइट आस्क समटाइम्स.
Sir, second heart, sir, when we will hear second heart sound, then during inspiration, it will be more appreciated.
Reverse split.
No, sir. Reverse split is in case of left bundle branch block or aortic.
नहीं, cause नहीं पूछ रहा हूँ. तुम क्लिनिकली कैसे बोलोगे ये तुम्हारा वाइड स्प्लिट है कि रिवर्स स्प्लिट है? नॉर्मली क्या होता है स्प्लिट को? नॉर्मली क्या होता है? इंस्पिरेशन में ज्यादा होता है, कम होता है?
सर इंस्पिरेशन में इंक्रीज
हो जाएगा ना, एक्सप्रेशन में कम हो जाएगा, मिलता नहीं है. If you are
Yes, sir.
able to appreciate split in expression, it is a reverse split, right? ये सिंपल क्लिनिकल के एग्जामिनर पूछते हैं बेड साइड आप कैसे बोलोगे, आपने बोल तो दिया बेड साइड कैसे हो, दिस हाउ डू डू. सो स्प्लिट अभी से आदत डालो बोलने का, और चारों एरिया को हटा के जैसे मैम ने बोला एक एरिया पे फाइंडिंग बोलना, और S1 हो गया, S2 हो गया, देन कम टू मर्मर. मर्मर के 6-7 पॉइंट जो भी है आपको बताना है, और इसमें इनफैक्ट तुम एक पॉइंट नहीं बता रही हो. डिड यू ऑस्कल्टेट एनी अदर एरिया अपार्ट फ्रॉम प्रीकोर्डियम? डू यू एक्सपेक्ट एनीथिंग इन दैट इस बच्चे में?
Sir,
हाँ बताओ कौन सा
sir,
एरिया
I
और देखना चाहिए था?
back of
Very
the
good.
child
एग्जैक्टली, एक्सेलेंट. सो बैक भी आना चाहिए, एक्सिला भी आना चाहिए, इसमें मेंशन करना पड़ेगा. बैक के लिए क्यों देखते हैं हम लोग? व्हाई डू सी फॉर दैट, लुक फॉर बैक?
sir, mitral areas murmur radiate करते हैं sir back.
एनीथिंग मोर?
इस बच्चे में बैक
इस बच्चे में बैक क्यों देखोगे?
इसको mitral disease नहीं, TOF means we are not talking about mitral disease. What do you expect? मतलब associated होता है quite commonly in 6 cyanotic patients. Collaterals,
right?
Collateral.
Yes.
Okay.
So this is very important. उसमें हो गए चलो.
Intercostal arteries, even there's no separate collateral, but even intercostal arteries become very prominent. They give feature to the pulmonary circulation, and you may get soft continuous murmur of those. So you have to auscultate back or TOF physiology patient.
पीजीज के लिए और एक सवाल एग्जाम में पूछा जाता है, टॉप में जो मर्मर मिल रहा है, जो आपने 3 ग्रेड 3 बताई, ये मर्मर कहाँ से आ रहा है? मेनी ए टाइम बच्चे बताते हैं VHD का मर्मर. एंड मेरे खुद चंडीगढ़ में एक पीजी था, ही काइंड ऑफ ही फ्लंक द एग्जाम नॉट ड्यू टू दैट, बट ही आंसर्ड कि सर ये VHD का मर्मर है, जो भी एक्सटर्नल आए थे पूछे थे. सो इट इज वेरी इंपॉर्टेंट टू रिमेम्बर कि मैंने जो है ना VHD के कारण मर्मर इसमें नहीं होता है, एंड व्हाट इज द रिलेशन ऑफ द मर्मर विद द cyanosis, right? This is very important to know. So these are some important things, at least top physiology के बच्चे में आप लोगों को पता होना चाहिए, and these are some of the important we need to. Right. चलो आगे move करो, time खत्म. We still have only 10 minutes left. Yep.
On doing other systemic examination, CNS was within normal limit, higher mental functions were intact, and there was no focal deficit. DTR
Right.
was +2 in palatal upper and lower limb, and plantar was palatal flexor. On doing respiratory examination, there was equal air entry, and there was no added sound. On doing parabdominal examination, shape was normal, it was soft, non-tender, and there was no organomegaly or no free fluid present.
So can you tell your diagnosis now? Anything more you would like to add?
No, sir.
No, sir.
Just summarize.
Fine.
And
Just summarize and give your diagnosis. Yep.
Sir, on examination, there was central cyanosis and grade 2 clubbing present, and patient is stunted and severely wasted. There was parasternal heave present, which I appreciated, and ejection systolic murmur was present. That was best heard over pulmonary area, and it increased with inspiration. There was no CHF by examining the other area, which we appreciated. So the differential diagnosis will be Fallot's physiology. Most provisional diagnosis will be Fallot's physiology according to this.
Okay, why tricuspid atresia? मतलब why only tricuspid atresia?
No, it should be tricuspid atresia with.
What are the things covered under TOF physiology? Can you just enumerate 1, 2, 3, 4, 5?
Tricuspid atresia with VSD and.
सबसे पहला वाला बताओ, सबसे important वाला बताओ.
So tetralogy of Fallow.
Yes, सबसे पहले वो आएगा. Yes, good.
And ma'am, tricuspid atresia with VSD.
VSD PS always has to be PS.
Yeah, VSD.
Okay, VSD PS बोलना ही है. GORV
double outlet right ventricle with
PS.
With VSD and PS. Yes.
TGA with VSD PS. Single ventricle with PS. Okay, everywhere you have to add PS. But it's just go before this prior slide. Huh? So summary, we don't write the examination finding. Summary is your history and examination ka combination and what you are concluding. Okay, so itna year-old child presented from this age with this history. On examination, these are my findings. So my differential diagnosis are those. Those 5, 6, 7 points means summary of everything, whatever you talked about till now. Okay, so you have a patient clinically what we get, we are not seeing the patient. So we have a child with top physiology presented with severe cyanotic spell to you. Okay. How will you stabilize him? Medical management.
Ma'am, for medical management, we first provide supportive treatment, like keeping the child in knee chest position by providing oxygen, and by calming the child. We can give morphine for that, or NS bolus at the rate of 10 ml per kg should be given if there is acidosis, and soda bicarb correction.
If there is acidosis, will you do APG in this child?
No, ma'am. We will give NS bolus at the rate of 10 ml per kg in case of cyanotic spell, and ma'am, soda bicarb can be given at the rate of 1 to 2 milliequivalent per kg. And if tachycardia is there, then we can give metoprolol, or if not available, then propranolol can be given. And if still cyanosis is present, then we can intubate the patient and we can completely sedate him.
Do you expect his cyanosis to go with this management?
Yes, ma'am.
It won't go, no, because he's having cardiac disease.
Yes, ma'am.
He will clinically become better. His spell will improve. His saturation may improve slightly. This time 40-50 hoga, abhi 60-70 aa jayega. Okay, but you don't expect this cyanosis to go. You don't need to. That is the thing we all need to understand. We don't need to intubate these cyanotic patient for cyanosis.
Yes.
Okay, if they are conscious, we need to make just them comfortable. So our target is make them comfortable. You can't remove their cyanosis. That is only after surgery. Okay, so you just need a medical stabilization with minimum invasive things. The more invasive you become, the more sicker your child will get. Because whatever prick you make, each and every prick will increase his heart rate. Increasing heart rate will make your child sicker. Tachycardia is not tolerated by any of the cardiac condition. Any. Okay. The first thing is make the child calm, comfortable, which it is best to give in mother's lap. Okay. Oxygen, if he's taking it is okay. If no, it is okay. Don't push on oxygen. That will irritate him. You need to avoid irritating things. Okay. Fluid is very important. Checking the hemoglobin and all, obviously, when you are putting cannula, you take out the sample in that. So your initial HB is very important. Arranging the things, and beta blocker is very important drug here. Very important drug here. Okay. What are the mechanism of action of beta blocker in these patients? It's like wonder drug.
Yes, it will
So how does beta blocker act with physiology in spell?
It will decrease the heart rate, so it will decrease arrhythmia, and it will decrease
arrhythmia nahi, hamara arrhythmia to hua hi nahi abhi tak na.
Heart rate will be decreased. So ma'am, the demand, the phase of diastolic and dilatation of the cardiac will increase.
Pehli cheez heart rate kam aaya.
Tachycardia will decrease. Yes. Second, cardiac contractility will be
क्या बीटा ब्लॉकर को रिलैक्स कर देंगे तो कॉन्ट्रैक्टिलिटी रिड्यूस कर देंगे. What? Yes, there is action related to
किसको रिलैक्स करता है ये?
The 5 points. Okay.
Infundibular dilation.
Infundibular relaxation.
Spasm को release करता है.
Yes. Okay. Because here that dynamic obstruction which is you said the intermittently many episodes of cyanosis, sweating. So what is that dynamic area? Infundibulum is because rest of the things are fixed. It is only infundibulum which is moving, which is making him intermittently sick. So what you are doing by beta blocker? Infundibular relaxation. You are reducing heart rate, so obviously heart is getting time to work. Then uske baad next chalo.
Infundibular spasm will be decreased. So
okay, infundibular spasm.
Anxiety, patient will become calm, as anxiolytic also.
It reset the respiratory, जो हमारा hyperapnea हो रहा है, it reset the respiratory hyperapnea center, respiratory center. Okay, then it shift your oxygen dissociation curve towards the right, release more oxygen. Plus, because beta we are blocking, alpha become hyperactive, so some increase in SVR is there. SVR बढ़ेगा तो आपका pulmonary blood flow बढ़ेगा. ठीक है, तो multiple actions are there. Top physiology patient, or obviously your heart rate has to be stable. You can't give beta blocker because hypoxic patients like this may have sinus node dysfunction because of hypoxia. So your basal heart rate is important. Don't give in a child who is already having bradycardia because some of them may have. There has to be tachycardia for beta blocker to act. Okay, but if heart rate tachycardia is there, beta blocker is the drug which save you in emergency. So fluid, anemia, infection, making him calm, teacher's position, beta blocker. Okay, these are the things we need to stabilize these babies.
सबसे important क्या करोगे नेहा? अब डॉक्टर मुनीश बोल रही थी को, तो I remembered my early days. I also worked with Dr. Savitri for 5-6 months. That was way back in 96, 97. The same thing. One day the child came with a hypercyanotic spell, as usual, just doing our pediatric residency. We are on the child, giving oxygen, pricking it. Madam, छोड़ दो बच्चे को एकदम से. Leave the child. Don't do anything. The first thing she told, calm the child. Don't irritate the child. Once you calm the child, everything will allay. उस समय SpO2 probe भी नहीं आते थे. हम लोग probe लगा रहे थे. बच्चा रोए जा रहा था. So as rightly
and
told,
like giving mother to feed, like feeding is such a calming thing.
Yes,
so,
yes.
Like minimum aggression, maximum comfort. That should be our thing in managing cardiac patient.
तो ये बहुत important है. ये we have to do. So this is very and sometimes we have to ask. एक चीज बताओ नेहा, ये ऐसे अब cyanotic spell हो गया, उस समय मरमर की intensity बढ़ जाएगी या घट जाएगी?
Decrease होगी सर at that period.
क्यों होगी?
सर
बता दो, बाकियों को बता, फ्रेंड्स को बता दो. हाँ
सर इंफंडिबुलर स्पाज्म और इंक्रीज होगा तो पल्मोनरी स्टेनोसिस सर इंक्रीज हो जाएगी, तो सर इजेक्शन सिस्टोलिक मरमर एप्रिशिएट नहीं होगा सर.
नहीं होगा. और साइनोसिस क्या होगा?
साइनोसिस इंक्रीज होगा.
क्यों इंक्रीज होगा?
सर बिकॉज़ सर शंटिंग भी उस समय से इंक्रीज हो जाएगी जो
राइट टू लेफ्ट. ठीक है ना. तो साइनोसिस, ये फिजियोलॉजी याद रखना है कि देयर हैज टू बी मिक्सिंग ऑफ सिस्टमिक एंड द तुम्हारा पल्मोनरी ब्लड मिक्स होगा तभी जाके साइनोसिस. देयर इज नो वे साइनोसिस कैन बी देयर एनी साइनोटिक हार्ट डिजीज अनलेस देयर इज सम फॉर्म ऑफ मिक्सिंग इन द चेंबर. So this is very or outside the chamber with some other communication. So very important. मैं एक चीज खाली हिस्ट्री में बताना, डॉक्टर मुनेश, ये अक्सर पेडियाट्रिशियन लोग बोलते हैं जब डायग्नोसिस आप बताते हैं, जैसे 5-year-old child, a case of heart disease, most likely congenital cyanotic heart disease, right? I am dealing with a child of tetralogy of Fallot with failure, without failure, right? No signs of infective endocarditis, sinus rhythm है कि नहीं है. Along with that, you add any complication, उसमें कोई cardiovascular complication है कि नहीं, और कोई precipitating factor है कि नहीं, along with the nutritional status. That way you cover all the areas. So when you come to management, everything will be covered apart from the top physiology. अगर nutritional भी उससे गया हुआ है, तो we have to, as a pediatrician, many a time we are more insisted, भाई बच्चा तो चलो साइनोसिस तुम भेज दोगे, रेफर कर दोगे, उसका न्यूट्रिशन क्या करोगे, तुम क्या करोगे, या एनीमिया कैसे ट्रीट करोगे. So they should come in the diagnosis. If they come in the diagnosis, you are going to manage that as well. So this is very important as a pediatrician. Whenever after the summary, as Dr. Munesh has nicely elucidated, try to speak the diagnosis. Not only in cardiac, in each and every case, try to speak with the diagnosis. So this is very important, right? And in fact, one more thing, in cardiac cases, we are allowed to see ECG and X-ray. If examiners say you take, but for that you have to have basic knowledge to interpret that as well. But you are allowed. Then only you can reach one or two important diagnoses, right? Yes.
What do you expect in X-ray, Neha? Show me the X-ray.
Yes, ma'am. Here's the X-ray. Ma'am, the CT ratio in this case was less than 0.5 when there was no cardiomegaly.
One thing is you always have to be sequential. So whether you are reading a heart or lung, you have to go sequentially. This is X-ray, what view, which phase of respiration, this is adequately penetration, rotation, hai ya nahi hai, cital solitus, levocardia, then come to the heart. So there is cardiomegaly or not? Okay, no, so start with that.
Okay, ma'am, this is a plain skygram AP view of 5.5-year-old female taken during inspiratory phase, and the exposure is adequate, and the bone were intact and there was no interruption. In airway, trachea was in midline, and And in coming to cardiac, the CT ratio was less than 0.5, and the cardiophrenic and costophonic angle were appreciable, and there was overturning of the apex here, and the pulmonary trunk area was hypoplastic, and pulmonary vascular area was prominent, but was mainly in the medial part of the chest. So depicting oligemic lung field here.
Okay, so no cardiomegaly, decreased pulmonary blood flow. Type of arch is left-sided or right-sided? Can you comment?
Ma'am, this arch is left-sided.
Left-sided. How do you see right-sided arch?
Ma'am, it is at the side of apex.
No, beta.
Like
arch,
yes, lateral view will.
No, in AP view only. Arch sidedness is decided by over which bronchus it is descending. So right arch will descend. Means it make an indentation on the right side of the trachea.
वहाँ लगाओ pointer लगाओ right side में ऊपर की तरफ.
नहीं, come down.
Come down. थोड़ा सा नीचे.
हाँ. यहाँ पे over the trachea, just go towards trachea. Trachea.
हाँ, medially
so
yes.
उतना ऊपर नहीं. It's like here. You will see a concavity here because of impression by the aorta there. Okay, so sort of indentation over the trachea. Pulmonary arteries or central pulmonary arteries are seen, but very thin, stringy vessels. Hardly any flow into, even in the middle third, you don't see any vessel. Okay, and we were talking about collaterals. Okay, MAPCAS, collateral. If there is any collateral suspicion, how will we see on X-ray? Do you have any idea? Like if you see the lower part of right cardiophrenic area angle, okay, here there is some spots, small dots. So like if you follow the vessel from above, but here there is additional. So I'm expecting some collateral in this area. So just a particular area will have some increased vascularity. Okay, because additional vessels. So I am expecting, because this is additional flow. Rest, if you compare rest of the lung, left and right sided. So could be there some collateral in this area, but that is different things. This is the way we read X-ray. So you don't expect cardiomegaly in TOF, you don't expect CHF in TOF, you don't expect heave in TOF, you expect single heart sound in tetralogy, that is A2, not PP. Okay, and your systolic murmur and all, everything you have. Do you have ECG?
Yes, ma'am.
थोड़ा सा enlarge करो, नहीं होगा नहीं.
But why only 3?
Yes, good.
It's another slide.
Acha.
Here in lead 2, ma'am, okay, it was regular in rhythm, and heart rate was 100 per minute. Ma'am, in lead 2, P wave was tented, and its height was of 3 mm. So, ma'am, I was
right atrial enlargement.
Yes, ma'am, right atrial, P pulmonale could be there.
Right atrial enlargement. P pulmonale, P mild trail, ये words better to avoid. Giving a name. Pulmonale, P pulmonale is like given with the COPD things. So the name came from that. Okay, what is the axis?
It's from right axis deviation is there. I mean, lead 1, there was negative deflection, and in lead AVF there was net positive deflection. So it was lying between 90 to 180 degree. So it was.
Give me one number. 90 ka number nahi de sakte na. You tell me one number. Roughly 100, 110, 150. Where you are? Like almost same one negative hai. Yes, almost same AVF positive hai. Okay.
Yes, ma'am.
So if you will come in between 150, 120. और precise हो जाऊं तो मेरा 145 पे एक्सेस आ जाए, 140 आ जाएगा. Okay, you have to be precise, है ना? क्योंकि आपको स्केल मिलेगा ड्रॉ करने के लिए. ठीक है, इतना वाइड रेंज 90 to 180 में नहीं चल सकते. We have to be 5 का प्लस माइनस चलेगा, but not 90 डिग्री का प्लस माइनस नहीं चलेगा. Okay, so right axis deviation. Now show me the chest lead.
नेक्स्ट वाले में होगा शायद.
Chest lead नहीं है?
नहीं लग रहा.
Okay, what do you expect in chest lead?
ये क्या होगा?
I think
No, yes, okay.
Ma'am, in case of chest lead, ma'am, also, ma'am, there will be right ventricle hypertrophy. So RV will be enlarged in V6, and RV1 plus SV6 will be greater than 25.
R wave enlarge in?
Ma'am, R wave will enlarge in V1 and
V1.
S wave will be enlarged in V6.
V6. So normally ulta hota hai. Okay. Then we don't have ECG here, but V1 you have RVH, R wave enlarged. When you come to V2, V3, there is sudden transition. You will get R and S almost equal. Okay, that is typical for tetralogy. When you have PS without VSD, that same R wave will persist with this severe PS. Okay, so that is the way we differentiate by ECG on in between PS with intact septum, PS with VSD means TOF. Okay, so test leads are very important to look for the hypertrophy, which chamber is enlarged, strain pattern. Okay, if it is critical PS with intact ventricular septum, you have strain pattern in your ECG for the right heart. Okay, so chest lead and limb leads both are important. You have to take a complete 12 lead ECG. Okay.
एक चीज बताओ नेहा, अभी कभी एग्जामिनर अभी बोलते हैं कि आप डॉक्टर साहब आपने टॉप फिजियोलॉजी बता दी है ऑल द स्पीसीज, अगर सपोज एक्सिस हमको लेफ्ट एक्सिस डेविएशन मिल रहा है तो क्या सोचोगे तुम?
सर ट्राइकस्पिड
-60 होता,
-60 होता, हाँ ठीक है।
ट्राइकस्पिड एटेरिया विद VSD एंड PS में सर लेफ्ट एक्सिस डेविएशन मिलेगा।
वेरी गुड। एनी अदर कंडीशन? मे बी, वेल आई डोंट एक्सपेक्ट, बता दो तो ठीक है। देखो तुम्हारे डिफरेंशियल में आ रहा होगा कहीं पे।
लेफ्ट एक्सिस डेविएशन इज अ फीचर ऑफ AV canal defect,
राइट।
ओके, जब भी आपको एक्सिस ये -30 -60 टाइप मिल रहा है ना, यू हैव टू थिंक फॉर द AV canal defect, वो सबसे पहले तुम्हारे माइंड में आना है। फिर RVH मिलेगा, लेफ्ट एक्सिस डेविएशन बट राइट वेंट्रिकल हाइपरट्रोफी, बिकॉज़ वेंट्रिकल्स अपनी जगह है बट कंडक्शन टिश्यू इज डिफरेंट। इन ट्राइकस्पिड एटेरिया यू वोंट गेट RVH बिकॉज़ RV हाइपोप्लास्टिक है, वहां लेफ्ट एक्सिस विद लेफ्ट वेंट्रिकल। ओके, सो उसकी अपना एक टेबल बन जाता है। नेक्स्ट sometime if I get the opportunity to interact with you, so we'll have
higher level पे, नहीं, it's good to that area। और कभी-कभी जैसे नया सवाल पूछेंगे, सपोज एक टॉफ का बच्चा आपने बोल दिया डायस्टोलिक मर्मर मिल रहा है, क्या सोचोगे तुम? I mean, it is difficult, I know it is difficult, but sometimes people read up and मिल गया, या फिर कंटिन्यूअस मर्मर मिल रहा है, क्या सोचोगे तुम?
This is सीसा मर्मर। Ejection systolic तो है ही, plus you are getting diastolic, तो आप स्टेथ रखते ही डायग्नोसिस बना दोगे।
Collaterals are present, तो
collateral is for continuous, collateral PDA for continuous, that Dr. Basu was, he's asking diastolic murmur। diastolic murmur मतलब either AR or PR, है ना?
yes ma'am।
AR in pediatric age group we usually don't see until unless it is secondary to bacterial endocarditis। PR, that is TOF absent pulmonary value, have PS plus no leaflet, so PS PR, PS PR, so this is very and they present with severe respiratory issues, so called CHF type presentation, life-threatening episodes, they present like that in infancy, not that late, sometime some special selection you can say nature. So that is the cause of, right. If somebody asks you diastolic murmur, either AR or PR, PR TOF absent pulmonary valve, AR secondary to this may happen in any patient.
Right. Now tell me the management, last 5 minutes, how will you manage this kid? अब सबसे important हुआ, आप क्या करोगे तुम, बताओ क्या काउंसिल करोगे, बताएंगे ना आप क्या करोगे तुम, what will you do?
सर पहले इनिशियली जो इनिशियल स्टेबलाइजेशन है सर साइनोटिक स्पेल का जैसा
ठीक है, कर दिया आपने,
तुमने कर दिया।
उसके बाद सर अगर मतलब सर अगर मतलब अगर विदाउट एनी काइंड ऑफ कोरोनरी मतलब एनी अदर एनोमली नहीं है साथ में, सिंपल टॉप फिजियोलॉजी है, सो उसमें हम लोग VSD क्लोजर एंड वो कर सकते हैं, वॉलॉटमी कर सकते हैं, सिंपल क्लोजर ऑफ VSD एंड वॉलॉटमी. If there is any other complications is present or any other anomalous connection is present, then we will go for BT shunt, and then further we will do the VSD closure and wall-otomy.
Okay, so age is important. Okay, he's a 5-year, he's grown-up kid. Now in 5-year, anatomy is again very important. So first thing is echo. You need to ask for echocardiography. On that basis, suppose I say you, as you are telling, TOF adequate anatomy. TOF adequate anatomy मतलब मेरा एक ही VSD है, मेरी pulmonary artery adequate है, मेरी coronaries अच्छी है, तो that you say total correction. VSD closure, infundibule resection plus minus valvotomy, total correction. If pulmonary arteries are very small, we go for stage surgery. Otherwise, even if coronary anomalies are there, you put conduit. But at 5-year, you go for the total correction. Okay, when you don't have pulmonary artery to work, okay, very high. Some patients have a very small pulmonary arteries. Then you do BT shunt or rectal stent. That is to give blood to the lung for pulmonary artery to grow. And then if they grow, then you go for total. Otherwise, at 5 years of age, whatever my anatomy is, if my pulmonary arteries are okay, I will go to the total correction. If coronaries are abnormal, you put conduit. If all okay, the surgeon can cut the infundibulum. So he just do a total correction in 1 stage. Okay. If it is infant, suppose 1 month old baby है या 6 महीने का है, या then आपकी बहुत सारे factors decide हो जाए. 5 साल पे आपको total correction ही करना. Okay. Very rare, you may have very small pulmonary arteries. Surgeon के पास जगह ही नहीं है काम करने के लिए, तो obviously उनको कुछ करके they need to go for the stage things. Okay, and overall tetralogy, total correction have a good prognosis. It is not a correctable lesion. Okay, not a curable but correctable lesion. So हम VSD बंद करेंगे, हम RVOG open करेंगे, but we give PR, pulmonary registration, to those patients. You cut the pulmonary valve, you develop PR. So 25% of them, even more than well, require pulmonary valve replacement in their life. 10 year, 20 year, 30 year, depending on how it is misbehaving. Okay, so we are correcting them. We are not giving a complete cure to the disease, because valve is abnormal. We are removing obstruction, but we are giving regurgitation. So lifelong follow. TOF patient post surgery, lifelong annual follow-up, maybe early depending on his clinical condition. Okay. So किसी भी पेशेंट, कोई भी पेशेंट, बहुत सारे पेशेंट आते हैं 30 साल पहले एम्स में ऑपरेट हुए थे या कहीं हुए थे, and they just disappear and they now come in a very bad shape. हमें तो किसी ने बोला ही नहीं था, ऐसा होता नहीं है, किसी ने नहीं बोला, बट हम सुनते नहीं है. So कभी भी कोई भी इस तरह से आता है, that they have to have a cardiac evaluation annually. Okay. So I think very well presented, Neha. Congratulations.
एक चीज सपोज आपने डॉक्टर मुनीश का सेंटर में रेफर कर दिया, पेशेंट बोला कि डॉक्टर साहब मेरे पास तो भाई कितने पैसे लगेंगे, आपने बताया मैडम ही बताएंगे, लेकिन कुछ तो आपका खर्चा होगा, 50,000, 60,000, 1 लाख जो भी है, ठीक है. अब पेशेंट बोल रहा है सर मैं तो अब नहीं जा पाऊंगा सर, अब क्या एडवाइस करोगे, जो कि हमारे सिचुएशन में द काइंड ऑफ जेंट्री वी सी इन आवर गवर्नमेंट सेटअप एंड ऑल, व्हाट एडवाइस विल यू गिव? सर्जरी इज द आंसर, व्हाट एडवाइस विल यू गिव?
सर लॉन्ग टर्म सर मतलब प्रोपेनॉल टू प्रिवेंट एरिथमिया.
हाँ, तो बताओगे ना, प्रोपेनॉल देना पड़ेगा, और क्या देना पड़ेगा?
सर आयरन सप्लीमेंटेशन इफ देयर इज
आयरन आपको, हाँ आयरन हैज टू बी गिवन. वेरी गुड. कितना हीमोग्लोबिन हम मेंटेन करना चाहेंगे इस तरह वाले बच्चों में?
सर अबाउट
मोर देन 15, 16 पीसीबी 16 है ना, मोर देन 15 से ऊपर करते हैं, ठीक है. और क्योंकि इसमें रिलेटिव एनीमिया होती है, एब्सोल्यूट वैल्यू पे हम नहीं जाते हैं, टू कीप द हीमोग्लोबिन लेवल हायर, राइट. और क्या कर सकते हो इसके अलावा? टेक केयर ऑफ हिज न्यूट्रिशन, ठीक है, इम्यूनाइजेशन एंड प्रिवेंशन ऑफ इन्फेक्टिव एंडोकार्डाइटिस. ये सब पॉइंट आप लोग ठान लो कि हमें सर्जरी के अलावा ये पॉइंट 5-6 पॉइंट हमें बोलना ही बोलना है, क्योंकि पीडियाट्रिक्स जब वाइवा होगा तो आपको जरूर पूछेंगे ये सब चीजें. आपने मिस किया, भले एग्जामिनर में नॉट बी दैट इंटरेस्टेड इन कार्डियोलॉजी, बाकी चीजें आपकी खिंचाई कर देंगे. सो वंस यू हैव टोल्ड,
Oral hygiene is
infective
very-
prevention में हाँ, yes, oral hygiene, how to and जो भी avoid करना है. So ये 4-5 points very important. So with this, I think, I mean, we both of us concur. It was an excellent case presentation. I wished other PGs could have asked. I don't know whether they are in the. I mean, कैसे Dr. Salaf कैसे connect करेंगे अगर पूछना चाहे. And I must thank all the faculty members, Dr. Yadav and Dr. HUD madam.
Putting the questions in the chat box. We don't have any questions. I think you didn't give any chance because the discussion
Hey,
was
Baba,
so
that is very
engrossing
bad.
right
That
from the
is very
beginning to
bad.
the end.
We have been overwhelming, Dr. Munesh.
It was such an exhaustive talk, sir.
Dr. Ajeet, I would like to have your opinion about this. How was the experience?
Yes, sir. It was a great experience, and I must assure you that in coming future we will actively participate in this program. And being the new faculty, I have started this activity, PG activity, and I assure you I will be joining you frequently with these kind of teaching programs. And I must thank Munesh ma'am and Basu sir for giving this exhaustive uh, uh, guidance to our PGs. And I'm sure that all PGs must have been benefited, especially exam going PGs. So thank you, Sarab sir, AOP, UP, and all the team for organizing and keeping this program for our PG students. Thank you very much.
Thank you, Dr. Ajeet. I must like to congratulate BRD Medical College, Gorakhpur's Pediatrics Department and the mentorship of the HOD, Dr. Anita, Mehta, and Dr. Ajeet. Dr. Neha, you did a splendid job and you really set up the case so nicely. And you have were up to some very accomplished cardiologists, a very renowned one, Dr. Srikanta, Dr. Munesh, and you still
Dr.
stood
Munesh
to
is
your...
the main cardiologist.
And you still stood to their tests, and I must congratulate and thank the experts, Dr. Munesh and Dr. Srikant sir. आप लोगों का coordination इतना perfect था, आपने इतने प्यार से पढ़ाया, इतने दिल से पढ़ाया, डूब के पढ़ाया और इतना simplified पढ़ाया और इतना इसके बाद भी इतना depth में ले जाकर पढ़ाया, right from the history to the management, and gave so many tips. I think जो भी audience में हमारे PGs हैं, there must be really treasuring them, and we will upload this session like all others on a YouTube channel, so that those who have missed out, they can visit them. I have no words to thank Dr. Munesh, Tomar, and Dr. Srikant Basu for agreeing and sparing the time and taking their heart out for this heartful session on the heart disease. Thank you very much. Thank you all for joining.
Thank you, Dr. Salaf, for all the adjectives, the flowery language and adjectives you are used. And it was pleasure meeting Neha. Once again, thank you so much, putting up so much hard work, and your mentors in your department and all the organizing team. And I also learned from Dr. Munesh as well. Every time I go into this kind of session, I pick up 1 or 2 things from our esteemed cardiologist, be it Dr. Munesh or someone else. Thank you so much once again.
My pleasure, sir. Thank you.
My pleasure.
Thank you, everybody.
Thank you, everyone.
Best
Thank
wishes
you.
to everyone.
Thanks.
Thank
Yeah.
you.
All